طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. هنتكلم عن fetal lung maturity diagnostic dilemma with practical point of view, because we have in the literature many articles on the how to detect the fetal lung maturity, but we want a practical point, because when we do an ultrasound for a case, we have to reach this in limited time. So I will screen first what are the different modalities to reach the fetal diagnosis of fetal lung maturity. Fetal lung maturity is vital to the survival rate of neonates. Neonatal respiratory distress syndrome and associated complications account for 28% of neonatal deaths. Neonatal respiratory distress syndrome results specifically from a deficiency in pulmonary surfactant, resulting in lungs that are developmentally immature and prone to collapse. Although the wide use of glucocorticoids has decreased the incidence of neonatal respiratory distress syndrome, 10% still will develop the syndrome. Accurate pre-delivery assessment of the fetal lung maturity, especially in high-risk pregnancies, those who we have to do elective cesarean section, for example, is critical to improving the neonatal survival rate. We have several antenatal tests have been developed in an effort to predict the likelihood of fetal lung maturity, like the lysis and sphingomyelin ratio. Many of the tests that necessitates amniocentesis, which is an invasive procedure. Yet they do not have a reliable predictive value, especially in late gestation, and are invasive because they are requiring amniocentesis. So in contrast, ultrasound examination is non-invasive and widely available for pregnant women. The normal fetal chest, here is the normal fetal chest. It is rounded or oval, with the ribs surrounding more than half of the circumference of the chest. A proportional growth of the fetal chest, lungs, and heart is seen with preservation of the cardiothoracic ratio throughout gestational age. But first, in the early gestational age, the lungs appear hypoechoic compared with the liver parenchyma, and then with advanced age, the fetal lungs become more fluid-filled, which results in increasing its echogenicity. This is a long list that we can use to detect fetal lung maturity. First, the placental grading. Placenta grade 3 is usually associated with mature lung, and usually, and many researches have been done. If you search the literature, they found that placenta grade 3 is usually associated with mature lung. Second, the amniotic fluid free-floating particles. If the length of these particles more than 5 millimeter, then it is with lung maturity. The bowel echogenicity, grade 3 colon, echogenicity of the bowel reaching that of the liver, means that indicates fetal lung maturity. The fetal epiphyseal ossification center. The most common is the distal femoral epiphysis that we always see. The distal femoral epiphysis بيبقى less than or more up to 1 millimeter than the proximal tibial epiphysis. The distal femoral epiphysis and the proximal tibial epiphysis combined lengths more than 11 millimeter. If you measure the distal femoral epiphysis and the proximal tibial epiphysis combined lengths more than 11 millimeter, and when you find that the proximal humeral epiphysis is present, we used to see the distal femoral epiphysis, and usually this epiphysis بيبقى من 3 to 6 millimeter in diameter. Then came the lung-liver echogenicity ratio, and this is very important. If we will see how we can measure the echogenicity in a number, but most of cases we do it subjectively when we see that the lungs are more echogenic than the liver. The kidney length is one of the parameters. If it is more than 4 centimeter, means that the fetus is mature. Increase the thalamic echogenicity, and fetal pulmonary artery Doppler, we measure the acceleration and ejection time with cutoff value more than or equal 0.3 0.3. So this is a great list of assessment of the fetal lung maturity. First, placental grading. This is placenta grade 3. How we found the placenta grade 3, where we found here the calcification is seen passing from the chorionic surface to the basal surface of the placenta with basal calcification. The cotyledons are as if they are drawn by this calcification, so this is grade 3 placental maturity. Then the amniotic fluid floating particles. Not all particles you see here, this is turbidity. Sometimes we see turbid fluid just due to the fetal movement, because this amniotic fluid is not clear fluid. It contains particles all the time throughout gestation, but we found these particles more than 5 millimeter here. This is floating echogenic particles, mean that this fetus has well developed vernix and hair, and there is shedded particles in the amniotic fluid. So this is what is meant by the free floating particles, or that we used to say in our reports, turbid liquor. Then the bowel echogenicity. Here, this is the echogenicity of the bowel. The haustra is well developed, and the colon is filled by meconium, and it is similar to the echogenicity of the liver. So this is what is mean. It is grade 3 bowel echogenicity, that it contains meconium, and this meconium is near to the liver echogenicity. The most important that I depend on in my practical work is the lung expansion and the lung echo pattern, which is the increased echogenicity, as we have said. How we can determine the lung expansion? Note here in this fetus, there is good respiratory movement. This is the diaphragm, this is the liver, and this is the lung. Note the difference in echogenicity is outstanding, even if we did not measure by the measure that I will say later in the lecture. So here, this is the lung and this is the liver, more echogenic than the liver. And then when you see the chest, here the chest with the abdomen are in one line. So here the chest is good expanding chest. This is the thymic gland and the atrium, and this is the thymus. And this is the lung. So this is how the lung are perfectly expanding in this fetus. To compare, this is another fetus where the chest is narrow. It is dumbbell shaped. Note here, it is dumbbell shaped chest. So this is a hypoplastic lung, and this was a case of phacomelia where we can see how the lung is, and usually this baby died from the hypoplastic lung. So this lung is not mature. This is the liver, and even the lung here we could not see. This is the narrow, very narrow chest cage, and here this is the thymic gland, but hardly you can see a lung. Again, this is the normal expanding chest, and this is the small hypoplastic lung. This also, here is the same case. Note how the chest cage is very small in size. The heart more than half the chest circumference. The lung here is more than half the chest circumference, while the abdominal circumference is good. Here is the abdominal circumference, and this is the chest. This is what means that the chest, this is a hypoplastic lung pathological, but sometimes when the lung is not expanding, we find a narrow chest as regard to the abdominal circumference. This is the abdominal circumference, and this is the narrow chest. Then to the more advanced and sophisticated examination by the 3D. By the 3D, when the machine contains the vocal software, we can detect on multiple slices using the 3D, and we can calculate the lung volume, and this is very important. I said that I usually do this subjectively when I found the thoracic cage expanding comparable to the abdominal circumference, but using the 3D lung volume using vocab is very precise because we can detect the lung volume corresponding to the age. Is there tables to that? Yes, there is tables to the lung volume. Here is the volume of the right lung compared with the gestational age, and this is the volume in cubic centimeter. And here is the left lung. This is the right lung, and this is the left lung. This is by curve, and also there is many articles will found that they put the lung volume regarding the gestational age, regarding from the 2.5 percentile to the 97th percentile. So there is a very wide range according to the gestational age, and usually they do this up to 34 weeks, because after 34 weeks usually the lung starts to be mature, and after 37 weeks usually the lung are mature, and we have to look for other signs that we have stated before. What is the flare? Flare is the fetal lung liver intensity ratio. This is to measure the liver lung ratio, but objectively, not subjectively. Yani subjectively, I see that the liver the lung is more brighter than the liver, but someone say no, it's so bright, it's nearly the same. So to cut it off, we can do this using a measure. In the early stages of pregnancy, the echo density results of the lung are less intense than those of the liver, and then starting from the 31 to 33 weeks, the echo of the fetal lung become coarser and brighter, while the echo of the fetal liver undergo little change, so there will be a difference between the fetal lung and the fetal liver. The fetal lung liver intensity ratio become more than 1.1 after 34 weeks gestational age, and on a statistical analysis that this density or this ratio is correlated positively with the gestational age. How we measure this? As we see here in this slide, here this is the lung and this is the liver, and we put a roi and we measure the ratio between both, as if we measure the density in CT, for example. So we put here and we measure the density, and here we measure, and then we calculate the ratio. The ratio in this case is 1.5, so it's fine. In this case, the lung echogenicity, of course, subjectively you can see that it is more echogenic than the liver. But in order to be precise, they do this measure, which is called the flare or the fetal liver-lung ratio. This case is immature. See here, they are nearly the similar echogenicity, but may someone say it appears a little bit echogenic, so we have to measure. So when we measure, we found it is less than 1. So here it is immature lung. Then came the pulmonary artery, the main pulmonary artery Doppler, and this was investigated many times. Investigate the effect of increasing gestational age on the Doppler waveform in the main pulmonary artery. في analysis of many of the Doppler variables, في some of the Doppler variables increased significantly with gestational age, mainly the acceleration time and the ejection time ratio, but also the peak systolic velocity, the end diastolic velocity, and the mean velocity increased with gestational age. The pulsatility index decreased with increasing gestational age, and the ejection time and RI do not change significantly throughout the gestational age. This is the normal wave in the main pulmonary artery. This is the normal wave in the main pulmonary artery. It's nearly a double peak like this, and here we have the peak systolic velocity, and we have here the time velocity integral, this part, and the T is the whole cycle, of the wave, and this is the diastolic velocity. And then we have also the acceleration time and the ejection time. This is the parameters that we use to measure in the main pulmonary artery Doppler. The main pulmonary artery Doppler, here we have a case where the PI is 2.2, the RI 0.8, and the acceleration time on the ejection time 0.84, and this means it's a good mature fetus. This is another case. And here the ejection time is low, ratio is low, so this is an immature fetus regarding the Doppler indices. And this study was carried by Dr. Yasmin Assam, she's lecturer of radiology in Cairo University. In her study, they show that there is a strong correlation between the main pulmonary artery, PI, RI, and acceleration time on the ejection time, with the decreased the development when it is this correlation is good with those developing respiratory distress syndrome and those without respiratory distress syndrome. And in this study there was cut-off value for each. If the main pulmonary artery PI 2.3 to diagnose between immature lung and mature lung, also the RI and the acceleration time on the ejection time ratio. But still, it's very difficult to detect the main pulmonary artery, especially in late pregnancy, because sometimes the ribs are well ossified, the position of the fetus, we could not get it well. So although it is very specific, but practically, in practical working, it's difficult to get. This means that fetus that develop respiratory distress syndrome have higher pulmonary vascular resistance, higher pressure, and low pulmonary blood flow, when compared with fetuses that do not have respiratory distress syndrome. And she has another observation in this research, that we found that those who take steroid intake, they show that it enhances the maturity of the lung, and many of them do not develop respiratory distress syndrome. And there is significant increase in the during taking steroids, there will be significant increase in the main pulmonary artery PI, RI, and acceleration time, ejection time ratio, and also in the signal in the echogenicity of the lung. Okay, then we will have some cases to see how we manage practically. We say from the literature most of the items that we could fulfill. We must correlate all this that we have said with the fetal biometry, the fetal biophysical profile, and the fetal Doppler. Because if we have the lung borderline and we found that it is not well mature, you must do Doppler. If the Doppler is good, the amniotic fluid is normal, and the biophysical profile is normal, then better to wait to get more developed lung. And the baby can take the mother can take corticosteroids in order to check for more maturity of the lung. This case was sent 37 weeks, and her doctor sent for fetal lung maturity for elective cesarean section. We will take the parameters that we have said before in this case. First, regarding the placental maturity, it is grade 3 placenta. Here there is the cotyledons seen and the calcifications that start from the chorionic plate to the basal layer of the placenta. So we have here grade 3 placental maturity. Okay. Then here we have the lung-liver ratio. That's what I say to you, that the ribs sometimes, this baby is occipito-anterior, and the ribs show much shadowing here, that we have to get to and through in order to see the echogenicity of the lung, and more difficult to get the main pulmonary artery Doppler. Here is the lung, the chest is well expanding. And here is the echogenicity of the lung and liver, and here the lung is more echogenic than the liver. And this is the sign that I have tell you, good expansion of the chest, good expansion of the chest. Then Something that I have not said because it's not so much written in the literature is the arterial perfusion of the lung. Here when we see the perfusion of the lung, we found that the vessels pass to the outer third of the lung, so there is well perfusion, and this well perfusion you will see it only in the mature lungs, the expanded mature lungs. Okay. Again, moving echogenic particles. Here is the moving echogenic particles, and when we measure one of these particles, it is 0.5. So it's good index for fetal maturity. Moving echogenic particles. And then, as I told you, the amniotic fluid index is good, and the biophysical profile is very good. The patient in the 50th percentile or 56th percentile, and everything is very good. So we are towards that we have good fetal lung maturity, good fetal movement, no IUGR, no gross restricted fetus. So all is very good. So you have to take all the parameters, not only start to search on the fetal maturity in specific. Then came the Doppler, and this is also a normal Doppler. Here the RI and PI are normal within the umbilical artery, and this is the middle cerebral artery showing RI 0.8. So we have normal Doppler indices, normal biophysical profile, normal amniotic fluid index. Then this case I wrote it that it's good fetal lung maturity, and sent for her obstetrician to book her whatever he wants. Then here another case. This case was sent as being post date. It's nice boy fetus, and here when we do the biometry, we found that it's very small on date, but I think it's only miscalculation because the baby was very good. I will see you all the indices of the baby, all is very good. So I thought that the mother has miscalculation, although she's insisting that she knows the period well, but this I didn't see that here there is nearly 1 month lagging. Regarding the lungs, beautifully mature lungs. Here the lung is the chest is expanding. The lung echogenicity is more than the liver. So we have here good lung maturity. Note here the expansion of the chest. It is comparable to the abdominal circumference. And here we can see that the lungs are hyperechoic than the liver. And we found the normal ratio between the heart and the chest. Then came here also the placenta. It's also grade 3, or starting to be grade 3 maturity. And here is the moving echogenic particles. And then here also is the ossific center of the distal femoral epiphysis. This is the ossific center. So it's good enough. And also the colonic haustra are well developed. With the echogenicity is not so near to the liver, but it's about to be near to the liver with the echogenicity of the meconium within the colonic parts. Then came also to the Doppler, nice Doppler. Here, this is the RI in the umbilical artery 0.5 and the PI 0.76, while the RI in the middle cerebral artery 0.86, which is normal ratio of the cerebro placental ratio. And here also is the here I tried to get the main pulmonary artery Doppler, and it is also with normal range regarding the fetal maturity. Another case, what you can say, it's normal expanding chest, good respiratory movement, echogenicity of the lung to the liver is higher, but in this case it's not so much high. Here there is a difference, but not so much high. In that case, if we can use the FLAIR to measure the ratio between the lung and liver, it will be better, of course. And this is the ossific center in the distal femur, and this is the placenta is not grade 3. The placenta here is not grade 3, but here the mother is very good, and I think we can wait and see, because I think she is miscalculation, and I wrote that in the report that I think it is miscalculation rather than small four-date fetus or gross restricted fetus. The kidney length, how to measure the kidney length, and here the biophysical profile is in this case, this is the third case. In this third case, she's overweight. She's overweight, but here it is 38 weeks. I asked the patient if she's diabetic, but she said no. So here the problem is the large four-date fetus, not small four-date fetus, and so she may be a case for cesarean section. But the lungs are mature, he can do cesarean section if you want anytime. The Doppler is okay. This is although there is a notch here, and some articles comment on the notch in the umbilical artery, but the RI and PI are good and normal, and this is the middle cerebral artery Doppler, normal of course. Okay. If there are other modalities, yes, fetal MRI can do also. We can do assessment of the fetal lung maturity by fetal MRI. The fetal lungs are homogeneous and hyper-intense compared with muscles on MRI. They show an increase in signal intensity after 24 weeks of gestation, and this increase in signal resulting from the increased amount of fluid present in the lung parenchyma as the alveoli develop. We can use both T1 weighted image and T2 weighted image aid in the differentiation of normal lung parenchyma and adjacent structures such as the mediastinum, the liver, and bowel. The lungs are hyper-intense compared to the liver and spleen on T2 weighted image. This is hyper-intense lung compared to the liver and spleen, and it is a sign of fetal lung maturity. And so also the lung expansion, as I say, in ultrasound. This is the fetal lung volume as we measure by MRI. Same as ultrasound, we can take many slices and add them in the end to calculate the fetal lung volume. And this is the increased signal intensity in all T2 weighted sequence and on FLAIR image, and decreasing signal on T1 weighted image. So the signals are increasing on T2 weighted images and the other sequences, and become decreasing on T2 weighted images. And also here a sign of maturity is the distended colon with meconium, which is also a sign of maturity in late stage here in 36 weeks. Thank you. Hope that the opinion reach you, but nothing is 100%. So we have to take care to see all the parameters in order to assess for the fetal lung maturity. Thank you.